Let's just dive right in. Here's our roadmap. We're organizing this whole thing into 6 logical buckets: breast infections and abscesses, common benign breast lumps, mastalgia and breast cysts, navigating nipple discharges, anomalies and gynecomastia, and finally, clinical examination essentials.
Starting with Section 1, breast infections and abscesses. How we manage these really comes down to the patient's stage of life.
So, let's up at the big divide here. First, the lactational abscess. This is by far the most common, happening in lactating mothers. The usual culprit? Staphylococcus aureus. But you know what's wild? The actual source of that bacteria is the oropharynx, literally the mouth of the nursing baby. Now for management, you definitely don't just jump straight to the scalpel. If pus is present, you attempt an ultrasound-guided aspiration at least twice before ever resorting to a full incision and drainage. Then, on the flip side, we have the duct ectasia abscess. This strikes a totally different demographic, mostly perimenopausal women. And instead of just staph, you're suddenly dealing with a nasty mix of both aerobic and anaerobic bacteria. That means you need broader antibiotic coverage and, quite potentially, a surgical procedure known as Hadfield's cone excision.
Okay, this next point is absolutely crucial, and it's all about timing. Say a patient comes in with pain, fever, and swelling. Do you wait around to feel that fluid-like shifting under the skin, that sign we call fluctuation, before you actually do something? Absolutely not. No way. In the breast, much like in the parotid, palmar, plantar, and ischiorectal regions, fluctuation is a notoriously late sign. Never ever wait for fluctuation to start antibiotics like amoxiclav or cloxacillin. You have to treat early.
Moving right along to Section 2, common benign breast lumps. These are the most common presentations we see, especially in younger patients. Before we get into specific lumps, we really need to nail down this term, A&D. It stands for aberrations of normal development and involution. Sounds super academic and complex, right? But honestly, it's just a catch-all umbrella term. It perfectly groups together all the non-cancerous, physiological changes the breast naturally goes through over an entire lifetime. Literally, from early development all the way through menopause.
All right, let's compare the two real heavy hitters of benign lumps. First up, the fibroadenoma. This is the single most common cause of a breast lump, usually popping up in young women aged 15 to 25 as a firm, mobile, painless mass. It's totally a radiological diagnosis. It'll usually show up as BRADS2 or even present with this classic popcorn calcification on a mammogram. And fun fact, while they're usually solitary, about 10% of patients get multiple. There's literally a documented case of one patient having 39 fibroadenomas. Can you imagine? Contrast that with the phyllodes tumor. This one shows up a bit later, usually in the 3rd or 4th decade of life, and it grows incredibly fast, often causing these dilated veins right on the chest wall. Now, the absolute vital difference here? You cannot diagnose a phyllodes tumor with a simple needle poke, like an FNA. You absolutely require a true cut or excisional biopsy, because counting the mitotic figures is the only way to see if it's benign or malignant.
Now, because the risk of a fibroadenoma turning into cancer is basically zero, we definitely don't always operate. But if a patient hits any of the criteria we're looking at here, like severe cosmetic concerns, actual pain, rapid growth, a strong family history of breast cancer, or if it's a giant fibroadenoma over 5 centimeters, then we step in. And the great news is, today we use amazing, essentially scarless tech. We can use cosmetic periareolar incisions, or a vacuum-assisted biopsy, or VABE, which uses just a tiny 2mm nick to remove the lump piecemeal right under ultrasound guidance.
Real quick, jumping back to phyllodes tumors for a second, because there is a massive, high-yield exam fact to remember here. If it does turn out to be malignant, it does not spread through the lymphatic system. It actually spreads hematogenously, meaning right through the bloodstream, most commonly straight to the lungs. Because less than 10% ever go to the lymph nodes, you absolutely do not need to do an axillary lymph node clearance during surgery. It's exactly like how we manage gastrointestinal stromal tumors, or GISTs.
Which brings us to Section 3, mastalgia and breast cysts. Let's talk about managing breast pain.
We generally divide this pain into cyclical and non-cyclical. Cyclical mastalgia is directly tied to the menstrual cycle. It peaks just before a period and is often linked to fibrocystic disease, usually in 25 to 40-year-olds. So, here's how we escalate that treatment. Step 1 is all about lifestyle. Weight loss, a really supportive sports bra, and cutting way back on tea, coffee, and chocolate. If that doesn't do the trick, we move to Step 2, vitamin E and primrose oil capsules for 2 solid months. And if that pain is still stubbornly hanging around, Step 3, we bring in low-dose tamoxifen. This is highly preferred these days over danazol, simply because danazol carries way too many harsh side effects.
But what if the pain has literally zero to do with the menstrual cycle? Let's contrast two non-cyclical causes. First, think about Tietze syndrome. This is essentially costochondritis, which is just inflammation right at the costochondral junction of the ribs. If you press on that spot, it is excruciating for the patient. The fix for that? A quick intralesional injection of triamcinolone, which is a long-acting steroid. Then compare that to Mondor's disease. This presents quite differently, as a visible, painful, cord-like structure on the side or bottom of the breast. It's actually superficial thrombophlebitis, meaning a clotted, inflamed vein, most commonly the lateral thoracic vein. The treatment here is super straightforward. Simple analgesics and a little bit of time.
All right, Section 4, Navigating Nipple Discharges. Here, color and source tell you everything.
I actually want to ask you this directly, right now. What do you think is the single most common cause of pathological nipple discharge? Think about it for a second. Lock in your answer.
Got it? Okay, here's the big reveal. The most common pathological cause overall is duct ectasia. Ectasia affects perimenopausal women, it involves multiple dilated ducts, and it produces this distinct greenish or bluish discharge. If we need to do surgery for it, we perform that Hadfield's cone excision we mentioned earlier to remove those multiple ducts. However, and this is a big however, if we are talking specifically about bloody discharge, the most common cause is a duct papilloma. This is usually coming from just a single duct, and because about 10% of papillomas can be associated with DCIS, which is a type of precancer, we definitely have to remove it. We use a tennis racket-shaped incision to perform a microductectomy, very carefully removing just that one single affected duct.
Now, what if the discharge is actually coming right off the surface of the nipple? There's a vital difference to catch between Paget's disease and eczema. Paget's is usually unilateral, just on one side, and it literally destroys the nipple areola complex. You have to diagnose it with a punch biopsy, not just scrape cytology. And here's the real, absolute kicker. In 70% of Paget's cases, it's actually just the superficial, visible manifestation of an underlying cancer hiding deeper down, usually DCIS. Eczema, on the other hand, is usually bilateral, completely spares the nipple complex itself, and clears up pretty well with topical steroids.
Section 5. Anomalies and gynecomastia. Shifting gears into congenital issues in male breast enlargement.
First up is an anomaly that frequently pops up on clinical exams, and that's Poland syndrome. This is a congenital condition characterized by the unilateral absence, so missing on just one side, of both the pectoralis major muscle and the breast tissue. It's a very stark, very noticeable anatomical absence that you definitely need to be able to recognize instantly.
Now, 19 to 21. What exactly does this specific number represent? Well, if a patient is suffering from severe neck and back pain due to breast hypertrophy and they opt for an inverted T or WISE pattern breast reduction, the surgeon has to map out an equilateral triangle from the suprasternal notch down to the nipples. The precise distance required between the two newly placed nipples to ensure perfect anatomical symmetry, it's exactly 19 to 21 centimeters.
Let's talk about gynecomastia for a minute, the enlargement of the male breast. It could be totally physiological, like during puberty, or it can be pathological. And one of the biggest pathological culprits? Medication. To help you remember the drugs that cause it, just use this fantastic mnemonic, DISCO. D for digoxin, I for isoniazide, S for spironolactone, and notably steroids, which you actually see a lot in gym goers who are trying to build six-pack abs but end up developing breast tissue instead. C is for cimetidine or ketoconazole, and O is for estrogen. Today, thankfully, instead of massive mastectomies, we treat this with a much more cosmetically superior combo of liposuction and simple gland excision.
Finally, Section 6, Clinical Examination Essentials. The physical exam techniques every student absolutely has to master. So how do you actually know if a lump is dangerously invading the chest wall? You guide the patient through a really specific 3-step physical exam maneuver to check for pectoralis major fixity. Step 1, you see if the lump moves freely, both along and then perpendicular to the chest muscle fibers. Step 2, you have the patient press their hands firmly onto their hips and really push. This mechanically flexes and makes that pectoralis major muscle completely taut. Then, step 3, you try to move the lump again. If it suddenly won't budge at all, it means the mass is physically tethered to that muscle.
And I really want to stress this one last incredibly vital physical exam tip. When you're checking the axilla, the underarm, for swollen lymph nodes, you must have the patient rest their arm entirely on your arm so their muscles go completely slack. And just like the quote says, always use the flat pulp of your fingers gently against the chest wall.
If you go in poking with your fingertips, you're literally just going to push the lymph nodes away and miss them entirely. You want to feel them subtly slip right under the pulp of your fingers.
We've covered it.